Okay, welcome everyone. We're going to get started. No, it's late in the day. Welcome. My name's Sean Rourke. I'm a scientist. I'm also the director of the OHTN here in Toronto for Ontario, and I'm the director for REACH 2.0. We're very fortunate to have this funding from CAHR, and it's the first center that's funded for program science and HIV. So we're very excited about that. It offers incredible opportunity. In my role at the OHTN, I've learned a lot from working in community and communities across in different sectors, and we're very fortunate to have the Ministry of Health AIDS Bureau to fund the OHTN. We've learned a lot about how do we fix things, how do we help look at problems and solutions. And today it's really about, you're going to hear a lot of terms about new terms, some familiar, some new. Research to action, bridge between science and practice, embedded scientists, all these terms. And we have a very distinguished group of presenters, keynotes, and discussants who will share with you their ideas, their thoughts about what program science can offer us in solutions. And it's very exciting to actually hear their thoughts. And there'll be a facilitated discussion in the second half where we really want to engage you and the panel on what are the opportunities for us in the HIV sector. We do incredible work, but we need to think about things that we can do differently. So I'm going to ask, so that's what I wanted to say up front. It's a pleasure. This is the inaugural session for program science at CAHR. We're very fortunate to have the support from CAHR Council and the co-chairs, Trevor Hart and Daryl Tan, to support this, so we're very pleased that they could find it within the program. I'm going to ask Chris Bunting to come up and say a few words, and then he'll introduce Jennifer, who will come up and introduce the keynote. So welcome and enjoy.
Thank you, Sean. I'm Chris Bunting. I'm the president of CANFAR. And I just want to take a second to say thank you for the chance to be here, for the chance to co-chair this, you're lucky I'm not, to co-sponsor this important session. CANFAR is committed to collaborating with other HIV and AIDS organizations whenever it makes sense. And to reflect what Bill Cameron said yesterday in his Mark Wainberg lecture, the more we can do together, the better our results will be. We're proud to be partnering with the other co-sponsors of this session, most of whom we are working with on a host of other initiatives. It's discussions like these on important subjects like program science that will help this community achieve its objectives more effectively and more efficiently, and ultimately bring this disease to its knees. I'm looking forward to hearing the keynote speakers and the ensuing discussion. And again, my thanks from all of us at CANFAR for the chance to participate today, and special thanks to our co-chairs. And now it's my pleasure to introduce Jennifer Gunning from CIHR. Jennifer.
Thanks very much, Chris. So I'm Jennifer Gunning. I'm the Associate Director for the HIV/AIDS Research Initiative at the Canadian Institutes of Health Research. And it's just a tremendous pleasure and honor for me to be here and to have the opportunity to introduce our keynote speakers and just hear what everybody has to say. There's an amazing group of experts in the room to present to us tonight that I think we all have a lot to learn from. This notion of program and implementation science is really an integral component of the new strategic plan for our HIV/AIDS research initiative, which was officially launched at lunch today. This concept of mobilizing evidence for greater impact on health of people living with and at risk of HIV/AIDS is one of the 3 strategic directions within our new strategic plan. So as an HIV initiative at CIHR, we're going to be moving more and more into this direction of implementation science, and it's a pleasure and an honor to be a sponsor of this event. And I want to congratulate the organizers for this inaugural program science session. Also, just I want to briefly introduce you to the keynote speakers for tonight. We'll start hearing from Dr. Nancy Edwards. She's a scientific director at CIHR for our Institute of Population and Public Health Research, as well as a distinguished professor at the University of Ottawa. After that, we'll hear from Dr. Ken Maher, who's the medical research director at the Fenway Institute, and then followed by Dr. Jamie Blanchard, the professor and director for the Center for Global Public Health in the Department of Community Health Sciences at the University of Manitoba. So I'd like to welcome Nancy to come up and give our first talk.
Thanks very much, Jennifer, and good afternoon, I guess almost good evening to all of you. It's been a long day, so we hope that we can keep you awake and alive, and I'm very much looking forward to the discussion. So I'm going to be taking a research funder's perspective on this and talking about implementation science even a bit more broadly than the area of HIV/AIDS, but that will be our focus. This is the whole area of implementation science is something that's under lively discussion around the world. These are just a few examples of some of the initiatives that have sprung up, many of them within the last few years, on implementation science. And we have lots of examples of funding councils that are looking at this area of science and seeing the elements of it that are new, and I think recognizing that there is a paradigm shift underway as we try to move some of the science in this direction. I would say there are sort of two streams of definitions of implementation science, and given that it is new, it's not surprising that we haven't landed on a single definition that everybody's comfortable with. And so my observations are that there's one area of implementation science which is sometimes used to mean knowledge translation. So that's when we've got the evidence that's ready to translate into action and to improve people's health. And that's reflected perhaps a little bit more with the definition there from David Peters, who's done a lot of work in this area. And David actually is the co-chair of our Institute Advisory Board. The second definition basically says, well, knowledge translation is critical. We have to go there. We have to be cognizant of how we're going to do knowledge translation right from the get-go. But actually, there's some gaps in the science that we've got, and we need to fill those gaps. And that's reflected in that definition that says research is about, in implementation science, is about what interventions work, for whom do they work, under what contextual circumstances or conditions do they work, and are they scalable in equitable ways? And I'm going to be speaking to that definition in my presentation. So underlying this emphasis and this interest in implementation science, I would say, are at least two shifts in paradigms that we have seen in the scientific world. One relates to a shift in paradigms around etiology. So we've moved from proximal and mechanistic approaches, and Hill's classic criterion that we've all learned in epidemiology are a good example of that, where we talk about biological plausibility, but we actually never talk about social plausibility. But we've moved to recognizing that there's actually a whole lot of more complex, cumulative, interactive mechanisms that are underway, and I think there's been a lot of advances in that area in the field of HIV/AIDS. And we see renaming of fields, evolutionary and systems biology, sex and gender, areas of understanding how is it that life stress, how is it that poverty, how is it that cumulative mundane exposures actually get under people's skin. We know as well in this kind of shift in the science that context is actually a really important part of the ideological, and that's also the intervention implementation causal chain. The second shifting paradigm relates to interventions, and of course we're all aware that the way you think about an intervention certainly determines how you study it. Penny Haw talks about that in some of her work. But there's been a bit of a movement here, I would say, from thinking about interventions as those that are theoretically, practically constructed by the researcher, and in fact best designed by the researcher, that the research somehow knows best how to design the intervention, to seeing interventions as events that occur within complex systems, and that they need to reflect an evidentiary base, a theoretical base, a system base, and also the tacit knowledge of clinicians and the tacit knowledge of our populations if we're actually going to be trying out and testing the interventions that are most likely to make a difference. There are, in the intervention field, many points of debate. I think these three are particularly pertinent to the implementation science paradigm I'm going to talk about. So one is this notion of heterogeneity, and this view that maybe if we have too many elements in our intervention and too much complexity and too much heterogeneity in our study settings, that it's a problem. in terms of figuring out what makes a difference. A second issue is around context and a view, and certainly the way I was taught, context just adds noise, so we want to try to control it, get rid of the noise to understand what's actually going on. And a third point of debate around intervention fidelity, and the view that if we lose intervention fidelity, we actually lose effectiveness. So Davidoff, among others, talk about the heterogeneity and points out that if we suppress it, actually we really lose something that's very vital to our understanding of what is it that actually works. And we know that heterogeneity is ubiquitous in complex systems. It is there. This is part of the real world. We see now in some of the most recently published guidelines from the MRC related to how to take context into account in process evaluation, examples of the many, many ways in which context does influence our thinking about the intervention itself, how an implementation process takes place, how the intervention and the context interact, and so on. So really speaking to the fulsome presence of context in the work that we do. And Pawson, who has done a lot of the work on the realist evaluation, talks about interventions being products of their context. The socio-ecological term I've added to that because that's really part of what he's talking about as you look at the contextual layers that he describes as being pertinent to the work that we undertake. This is some work coming from Chambers in Glasgow in the United States, where they talk about how we insert interventions into practice settings or institutional settings, and then those in turn are inserted within ecological systems. And they have a very interesting contention that relates to fidelity. So they say, traditionally we thought about, as you move from efficacy to effectiveness, we can expect a drop in the voltage, and we can expect a drift of the program, and that both of those account for the fact that often in effectiveness studies we see something that's got less power, it seems, to make a change than what we see in efficacy studies. But they argue that actually we need to rethink that perhaps this is problematic. Maybe there shouldn't be a voltage drop. Maybe if we actually adapt the intervention to the context, we could see an improvement in voltage as we move from efficacy to effectiveness and to improvement approaches, for example. And this is just their way of sort of showing how that adaptation might occur as you implement interventions into different contexts. So building on all of that, and just a couple more words about context, because I think this is really important. We see many, many contexts, and those that we pay attention to are probably largely driven by our own particular interests, the particular decision maker we're working with, what it is that we think we have the methods to actually tackle, but the context is very important. And as we think about task shifting on the global health front, or work to try to look at a different kind of integrated team model in Canada or in Jamaica, then we understand that it's the context of regulations and policies that are hugely important in what you can actually roll out. And as we think about Aboriginal populations in this country and the experience with residential schools, we understand that both historical and contemporary context is at work. And here we need to think about the context of colonization and the related context of stigmatization. So onto the framework I want to present. And this has been published, but I'll just go through it very quickly. So here we see that we often start with foundational sciences, often biological sciences, and some social sciences that inform our efficacy questions and our effectiveness questions. And that's usually sort of as far as we go with our paradigm, and then it's, let's just figure out how to translate that knowledge. But I would argue that actually there's another dimension to this where we need to go, and this is the integration, the adaptability, the scalability of the work that we need to do. And as we move up that paradigm, there are other kinds of foundational sciences that become really important. So political science, economic science, other social sciences, and so on, need to inform our thinking, our designs, our approaches as we move up this, this framework. And we see that the contextual elements are perhaps less pertinent when we start off with efficacy studies, but they become more pertinent, thus the inverted triangle, as we move up that, framework, excuse me. And those context dimensions include the contextual fit. So is the intervention actually responsive to the community, responsive to participants, responsive to the provider and the structure? the ongoing contextual adaptations, how is the intervention or interventions being adapted as we go, and the contextual uptake. What are the longer-term spin-offs? What is the longer-term sustainability of the intervention we're trying to put into place? Within that framework are embedded three axes. One axis has to do with how we frame the research question. A second axis has to do with how we control and implement the intervention. And the third has to do with determinants in some of those complex pathways I talked about in my etiology slide. And each of those axes exist on a continuum. So with respect to the research question, we can think of a continuum that has attribution at one end and adaptation at the other end. When we think about the intervention, we can think about a prescriptive and standardized intervention being an attribute at one end of the continuum and a very contextualized intervention being at the other end of the continuum. And then you see our determinants on the right, where proximal determinants, so one's education, one's biology, and so on would be examples of those, being at one end of the continuum, and socio-structural determinants like histories of colonization and so on, and racism being at the other. So just a little bit more on this. I would say that a lot of our efficacy questions are really attribution questions. We know that RCTs are the gold standard here. Intervention comparators may be important, but we're often usually examining specific hypothesized causal pathways when we're looking at attribution. Does A produce B when we test it out? Adaptation is looking at intervention adaptations within complex systems. It involves not intervention comparators, but system comparators. And I would say that mixed methods designs, not just mixed methods data collections, but mixed methods designs are what we need to look at that. With respect to controlling the intervention, fidelity is a primary concern, with some tailoring often to patients and populations being part of the prescriptive and standardized approach. At the other end of the continuum, how do we get internal and external contextualization of the actual intervention? And how do we create interventions that are actually responsive to a context which is dynamic? Context does not stand still. Context is highly dynamic in its contemporary form. And some of that dynamism is something we might anticipate, and a lot of it is stuff that we might not anticipate. And the third axis then, the proximal determinants, which I already gave examples of, and the socio-structural determinants, which are often embedded deeply within the structures of our society, our legislation, our policies, our ethnic profiling in our police system, it goes on and on. So this is just putting them all together, showing that, no surprise, the efficacy studies are really at the bottom end of that diagram. The effectiveness studies perhaps somewhere in between on those three continuum, and the adaptive implementation studies, I would argue, are at the top. We often talk about effectiveness RCTs as being the gold standard. When I'm punchy, and I'm punchy tonight, I say that the adaptive implementation studies are the platinum standard. And it's not that we don't need more efficacy studies and more effectiveness studies. This is critical work that has to continue in order to inform the adaptive implementation studies. But what we're trying to do within CIHR through a number of our initiatives, including the HIV/AIDS initiative that Jennifer has mentioned, is to try to build and strengthen the work that's going on in the adaptive implementation study area. And that, I think, often involves a paradigm shift for scientists. This just puts together the three types of research questions to provide some comparisons. I would argue that the community engagement potential is highest within implementation science, because I'm talking about an engagement potential that starts even when we're thinking about what should the question be. We look at eligibility and see that in efficacy studies, we're often trying to make sure we've got individual homogeneity. But in implementation science, we're looking for both individual and contextual heterogeneity. The understanding of context that comes out of this is different, focusing, I would say, largely on settings within the effectiveness field, but looking at more of that dynamic context, the inner context, the outer context as being relevant in implementation science. And finally, generalizability, where internal generalizability is our focus for efficacy, external generalizability for effectiveness, And Slim Haddad talks about transposition being where we need to go with respect to generalizability, which embeds in it this concept of adaptation. So how are we translating this into funding opportunities at CIHR? This has been a really interesting path for us, and we've been doing this both within the organization but also with other initiatives. One example that was out the door, perhaps one of the earlier ones, was the Pathways to Health Equity for Aboriginal People. I think Malcolm King may be here, so he's right over here. Some of you may want to speak to him. He's a lead on this along with ourselves. But these are just some examples to give you an idea of what it is we're writing into a funding opportunity to give a sense to people of what it is we're looking for. So these are examples of the objectives, looking at new insights and how interventions can be adapted. So there's the adaptation term, given populations that have particular historical and contemporary contexts, and looking at system change to deliver programs and policies. So you can see what I've been talking about now getting embedded in the statements of the funding opportunities. Here's another one. This is a Global Alliance for Chronic Diseases, which involves 9 funding councils from around the world, both from lower middle income countries as well as higher income countries. And you can see examples of the kinds of implementation science questions that we sort of threw out to the researchers who applied to get them thinking about what are we looking for. So what are the contextual influences, the leadership, the governance, the organizational culture that are required for the successful implementation of effective strategies? What about the interrelated policies? So there's a context piece that actually might support achievements in prevention, treatment, and management of chronic disease. And what networks and coalitions and intergovernmental agreements are in place that we need to be cognizant of as we think about the interventions that we need to undertake. And here's one final example from our community-based primary healthcare innovation teams, where we built into that funding opportunity a requirement that the teams had to work across jurisdictions. And it was a requirement because we were trying to make sure we had the contextual heterogeneity in the teams, so that we've actually got the comparisons of the critical differences in the way health services are delivered across our jurisdictions in Canada. So taking advantage of the fact that we are, we've got 13 laboratories and health services in our country at least at any one time. So just a couple of final things, because I've run out of time. Just some ideas about bridging implementation and improvement science, which I think links to what Jamie's going to talk about. So how do we support the meaningful engagement of those who have very deep knowledge of context? What does that look like? I think that requires some rethinking. And actually, I think other fields have quite a bit to learn from the field of HIV and AIDS on this, because you've had very deep community engagement for a long time. How do we build capacity and get the team composition that's necessary for the best-in-class research designs that we need for this area of work? How do we get those concepts embedded from the front end of peer through to peer review and journal reporting guidance, because there is a paradigm shift here? And finally, how do we advance knowledge synthesis methods that actually are going to take this intervention context interaction into account? And I would say that currently our knowledge synthesis techniques don't do very well in that regard. So looking forward to the discussion. Thank you very much.
Good afternoon. I want to thank Dr. Rourke and colleagues for inviting me to talk with you this afternoon. Dr. Rourke actually was the first person who I heard use a term that I guess describes why I'm on this panel, embedded scientist, and the idea that somebody can be spending part of their day in a community health center setting, but at the same time be on the faculty of an institution like Harvard Medical School and also do work in the hospital. And the idea is that much of what we have to do in HIV/AIDS and other disciplines has to really incorporate kind of seamless transition between those different worlds. So I'm going to be talking about PrEP as a case study in terms of implementation. And so the first question is, why PrEP? Many of you here in this audience have distinguished research careers basically showing that we have effective antiretroviral therapy. And certainly you have colleagues in Vancouver, like Dr. Montanar, that feel that, if we scale up treatment, we really don't have to worry about other aspects of prevention per se. But you can see here that in the US, we talk about our cascade, and basically less than 30% of Americans persons are suppressed on antiretroviral therapy. That's even more extreme when we talk about youth, where the infection rate is rising most quickly. So it doesn't mean that we don't focus on interventions to increase serostatus knowledge and to improve adherence for people who are diagnosed and in treatment, but we can't assume that that's going to be the holy grail in the near future. There's a rationale for pre-exposure prophylaxis. I think this is well known to many of you, but just to be clear, for other infectious diseases, we've used pre-exposure prophylaxis, such as when people come into areas with high prevalence of malaria. It's fixed and delimited, as people would say, whereas taking antiretrovirals for an uninfected person for the rest of their lives, does that make sense? Well, if we think about prevention of pregnancy, birth control, there are many analogies in terms of preventing something that may be sexually acquired, and having first-generation approaches, being oral with only one fixed combination, and moving into different modalities for different populations over time. The medication we know the most of is tenofovir disoproxil fumarate, with or without emtricitabine, and that's because it's safe, well tolerated, and the company that manufactured was permissive of these studies going forward. But as you'll hear today, we're just talking about PrEP 1.0 today, and the future will offer more modalities. There's an adequate bunch of studies now in terms of non-human primates that justify the rationale for the clinical trials. And as many of you who are following this literature, there's been a huge panoply of clinical trials over the past few years. So this is the most recent organization of the trials based on the data from the recent retrovirus conference. We have the definitive study in heterosexual discordant couples, the Partners PrEP study. Dr. Ronald is very well familiar with this work. And basically, this had the highest evidence of efficacy, 75% for tenofovir FTC. At the other extreme, you have several studies in women, FemPrep study and the VOICE study, looking at oral and topical tenofovir-based regimens and not showing any efficacy whatsoever. What we do have relevant for the North American context is 3 studies now that show the efficacy for antiretroviral chemoprophylaxis for men who have sex with men, the population that's most highly affected right now by HIV in terms of incident infections. So what's the difference between these studies? And basically, the take-home is PrEP works if you take it, but a lot of people were not necessarily motivated to take it in the context of the clinical trials. So with this plot put together by Dr. Slim Karim basically plots the drug detection overall in the clinical trials in relation to the efficacy estimate. So you can see that the studies, the partner PrEP studies, are way up towards the top because of 80% level of adherence overall, and that FemPrep and VOICE are towards the bottom, and Iprex in the study among Thai injecting drug users is somewhere in the middle. So adherence is clearly the issue. And then the question gets asked, why would people participate in a study if they're not intending to take the medication? And indeed, when drug levels were looked at in both the FemPrep and VOICE studies, there was a substantial population of participants who never used the medication. When they were interviewed, it was clear there were motivations for participation in trial to get the incentives, which help pay for family needs. There's also the perception that there was free medical care. It was a way to know that one's HIV status, that they were uninfected. And in some cases, even more interesting, some of the anthropological observations where some of the women said that they signed an informed consent that said the medication might not work and they might be getting a placebo, but they thought, well, if it did work, that would be a good thing. So they saved the medication in anticipation of knowing that it would work, but not wanting to have the experiment in their own body. So this speaks a lot to the need for the work of the researchers and the communities really to get an understanding of what the shared purpose is for the conduct of the clinical trials. The pharmacology, though, also plays a role. It's very clear that tenofovir FTC has higher concentrations in rectal mucosa and secretions than a cervicovaginal mucosa and secretions. This doesn't mean that PrEP using tenofovir-based regimens doesn't work in women. It may mean that there's less of a forgiveness factor, so that lesser adherence for this particular agent, given this particular way, may require a higher level of engagement for women who may be using the medication. There's been some very interesting work from the Caprisa group in South Africa South Africa suggesting also that in some of the women who are adherent, the very few who became HIV infected, they had high levels of genital tract inflammation, and so an intercurrent STI might mitigate the benefits. So you might have the combination of needing to be highly adherent and some untoward effect of the intercurrent genital tract infection that may make PrEP less efficacious for those populations, particularly in a population of women where a number of the women were engaging in transactional sex, where STIs were common, and where domestic violence was also not uncommon, and again could lead to traumatized mucosa. So clearly we have answers, but we also have questions for first-generation PrEP. One of the big questions is, what numbers do you use? And this really gets back to the whole theme today, which is that the efficacy trial, for example, in the Ipergay study, and we at Fenway Health in Boston were one of the two US sites for the study. The intent to treat analysis initially said 44% efficacy. That means if somebody signed the informed consent and never took the pills, but they were in the assigned group for the active medication, they were counted as a failure of the regimen. In a post hoc analysis of the Ipergay participants, looking at 51% of the patients who had drug detected in their blood, the efficacy estimate went up to 92%. One modeling study suggested 90% efficacy, and in an even more back-of-the-envelope post hoc analysis, and looking at when you try to say what are the array of levels, and levels consistent with taking the pills up to every other day, about 4 times a week, nobody became infected in the Ipergay cohort. So you could say, well, that might even be 100%, but we know that the sample size is too small, so the confidence interval is going to be wide. So we cannot say to anybody, you know, if you take this every day, you are 100% protected. We can say this analysis, post hoc analysis of the Partners PrEP study and other PrEP studies suggests that consistent use of this medication has a very high protective level, certainly higher than any data that we have for condoms in the real world, and certainly higher than for any behavioral interventions. And that's the reality we have to face, which is high level of reasons why people might not take the medicine consistently, but a suggestion that consistent medication use can be associated with a high level of protection. So there are a host of questions that people have raised. You know, there may be symptoms that people have. These are people who are not infected. Will that be tolerable? And there certainly are renal toxicities that tenofovir can cause. But with careful monitoring, the incidence of renal disease in the studies was extremely low. The drug can decrease bone mineral density, a very small amount, which tends to stabilize over time in people living with HIV. But what about young populations? So ATN-110 and 113 are studies that are going on in the US, looking at both behavioral interventions, a group versus a individual intervention for the youth, but also doing bone safety studies to make sure that if this medication is approved for 16, 17-year-olds who are still laying down new bone, we're not going to be doing something negative in the long run. The question of risk compensation, and the issue there we really need to reframe. The people going into these studies are people who would be offered PrEP are by definition people at some risk for HIV. People who are celibate are not going to be offered tenofovir FTC. Resistance, similarly, was something of a bugaboo, but if people are taking the medication on a consistent basis, they're not becoming infected, they're not developing resistance. If they're erratic, that's the problem. So let's just unpack this issue of risk compensation again. So the best case scenario, you have somebody who has no intention to use condoms, but they're very highly adherent, and therefore the likelihood of HIV transmission is very low. The worst case scenario, and this is where we are in the real world effectiveness studies, trying to understand, are there individuals who get the script but have erratic patterns of medication adherence and are not taking it regularly, and then you would select for resistance. This has fortunately not been seen a lot at the present time in the studies to date, but clearly this is where ongoing monitoring and implementation science is going to be very important. And this issue of risk compensation, certainly it's possible. Some people may increase their risk, but in the context of the trials where people were getting regular counseling and testing in the course of the study, this was not seen. People started at a fairly high level of risk. Many individuals decreased it somewhat at a modest level within the first 3 months, and then it asymptoted, and people, there was some regression towards the mean, but very little seeing people shooting up with increased levels of risky behavior, not consistent with their behavior prior to the study. So we're going to have to match our counseling messages to the individual circumstance. What I think is one of the most powerful studies to date is the PROUD study, which many of you are aware of from the retrovirus conference. So this was the British National Health Service saying, based on the Ipergay study, we're not ready yet to license PrEP in the UK because in the real world, people may not be as adherent as they were in a study with all that level of complexity. So this was a study done in several genitourinary clinics across the United Kingdom. Individuals were randomized to either be in a queue and be told that they would be given PrEP if the study showed efficacy subsequently, or to receive medication right away. So this was open label, real world setting for men who have sex with men presenting for GU symptoms. And the results were quite impressive. There were 3 infections in the individuals who were randomized to get PrEP immediately and 19 infections in the deferred group for an overall effect of 86% reduction. Going back and looking at those 3 infections, one of the individuals was a person who was antibody negative at screening, antibody negative when they enrolled in the study, but these were done with rapid tests, so not the most sensitive assays. And it turned out that this individual was in the process of becoming HIV infected when he entered the study. So he became infected. And then there were 2 individuals who enrolled in the study, started PrEP, decided they weren't that risky, stopped it, but subsequently had risk and became infected. So with intent to treat, they count in the column of lack of efficacy for the active arm. But it then gets back to the real world. As clinicians, we have to really pay attention. If somebody is about to become HIV infected, they should not be given PrEP. So really being sure that a person is not in that seroconversion window, and then monitoring people over time, because people may misperceive their risk. And certainly if PrEP is a crutch, but then the person doesn't use the crutch when they really need it, it's not going to be very helpful. The Partners PrEP study answered another important question. So this was the question with heterosexual discordant couples. Does it make sense to use PrEP? Does it make sense to start treatment early? So this was a demonstration project in a setting where both questions had been asked previously. Earlier treatment in HP10052, there were several of the sites in Kenya and Uganda who participated in that, and then also the Partners PrEP study. And this study basically argued against a counterfactual because of knowledge of the population, basically said that if individuals did not have access to either of these modalities, the expected HIV incidence in these serodiscordant couples would be 5.2% per year. The observed number of infections was really quite low, 0.2% per year. And the thought was that PrEP can be a bridge for individuals over time when an infected partner is going on treatment. We have to think about cultural tailoring. In the United States, we have extreme health disparities where the largest segment of the population becoming newly HIV infected are young black men who have sex with men. So in the HIV Prevention Trials Network, there's a demonstration project now focusing on cultural tailoring messages and training peer health navigators and case managers to work with black men who have sex with men and to look at the efficacy of PrEP in that setting. PrEP 1.0 is tenofovir FTC. You can see the pipeline. We have researchers here like Dr. Larry, who's been working many years to try to figure out other options besides oral medication to prevent HIV. And I commend this website, the AVAC website, avac.org, which keeps running lists. But right now you can see in phase 4, we only have tenofovir FTC, but many things coming through the pipeline. One of the other big questions is, what about being more parsimonious? If somebody's not having condomless sex every day, do they really need to be taking a pill every day? So the animal data certainly suggests that loading up prior to exposure, you can protect the animals. And the Ipergay study, with the site here, in Montreal, led by Dr. Tremblay, really was a definitive study. So 2 pills before sex and a pill a day after sex. And again, the same efficacy estimate as in the PROUD study, 86% reduction in HIV incidence, high levels of acceptability. I don't think many of us are ready to say this mode of using PrEP is the best way to do it for all individuals. I think there's some peeling away of understanding people's patterns of behavior better to know whether episodic PrEP is the best strategy for individuals. At the recent retrovirus conference, Linda Gale Becker presented data from South Africa in a study of young women at risk for HIV and looked at drug levels when the women were followed, either told to use PrEP in a peri-coital way or to try to take daily pills. And adherence was actually better with the daily pills. So we have this conundrum, or this almost this this paradox where in the efficacy studies, women weren't taking the pills, but in this observational study, daily pill use there was higher levels of drug detection than in intermittent PrEP. So clearly, more things we need to find out about people's patterns of sexual behavior, people's understanding of risk, and people's willingness to take PrEP. So what's happening in the real world? In San Francisco, in the Ipergay open label extension study, so these were people in a research trial, but then given open label medication, after 12 months, the vast majority of individuals were taking pills at least on a daily basis or 4 times a day. We know that adherence is the challenge. There are a variety of different technologies that are under study now to complement PrEP adherence. So based on the work of Lester and other colleagues at UBC working in Western Kenya, it was found that text messaging increased the levels of virologic suppression in HIV-infected individuals. So with my colleague Steve Safran in Boston, we've been looking at text messaging and a cognitive behavioral approach to try to get people ready for PrEP. And we found 84% after 6 months had drug levels consistent with daily use. There's work with electronic diaries going on in San Francisco, work in LA, looking at therapeutic drug monitoring and giving people feedback in real time if the levels are low. How widely is PrEP being used in the United States? Bob Grant presented data at the retrovirus conference suggesting that it could be as high as 31% of at-risk individuals in San Francisco. We did national studies on a social networking site, Manhunt, we did 2 waves in August 2013 and in January 2014. And if you look at the group of individuals in January 2014 having taken PrEP, and this national survey was still only 3.1%. When we did the multivariable analysis and looked at self-reported PrEP use, we found education, not surprisingly, was associated with PrEP use. Perceived vulnerability probably played a role, having had a prior STI, having used post-exposure prophylaxis being used to these medications. But one of the other key issues I think we have to deal with is that individuals who felt more comfortable talking to their partners about their providers about their MSM behavior were more likely to take PrEP. So we have a provider problem. Very quickly, postcards across the edge in the United States, they're slow uptake, but just slow but steady. At Fenway, where we've been doing PrEP work now for almost a decade, we have seen an uptick in 2014, and now we're averaging about 50 individuals starting PrEP per month, and I think other cities like New York are also finding this. I'm working with a young physician, Doug Krakauer, who's very interested in provider behavior, and we have what we call the provider paradox, the purview paradox, which is basically specialists in HIV feel that they don't take care of uninfected individuals. They don't want to be spending all that time doing the counseling. Primary care providers say these are difficult drugs to use. I don't feel that I'm adequate to do this. And you can see here in a recent survey of New England providers, which is a fairly liberal part of the country, that the majority of the attitudes that were expressed were negative attitudes, concerns about PrEP. So we still have a lot of work to do with providers if this is going to be uptaken. The CDC is trying to develop a risk score that providers might be able to use. At Fenway, we also use patient-reported outcomes, where we do behavioral health assessments twice a year in the HIV-infected population at the clinic. And this may be able to be developed into tools that busy clinicians can use to decide who's an appropriate candidate for PrEP. But we have to deal also with structural level issues. So this is a map. The Human Rights Campaign in the U.S., which advocates for LGBT civil rights, put a map together based on the laws in the U.S. So you can see dark blue is Massachusetts, marriage equality and civil protections. In the South, you can see states that have very low levels of structural level stigma. And the reason I show this is because we then went back and looked at the Manhunt survey, and we found that people who are in states where there was higher levels of structural stigma were more likely to be engaging in condomless sex and less likely to either know about PrEP or to be using PrEP. So the social environment is clearly another place where we have to intervene. We're trying to do our part. We have a variety of web resources on our website, and I just want to thank my colleagues at Fenway and several other colleagues for the information. I look forward to your questions. Thank you.
I wanted to first thank Sean Rourke and his team for organizing this really important session and for his leadership in putting this together and for inviting me to speak here. So I'm going to talk about program science in a little bit of a broader domain and try to end up at what we might be able to do next to move this forward. I'll start with an interesting encounter that I had maybe, it was about almost 6 years ago. I was doing what I guess professors do, sitting in my office in the university, and we had a distinguished set of visitors from Nigeria. It was a bit of a surprise to me. I didn't know they were coming. And one of the visitors was a governor of a state in Nigeria. His name is Governor Saswam. He's important. He's a governor of the state of Benue. And Benue State, for those of you who know the epidemiology of HIV in West Africa, has persistently had the highest prevalence of HIV over the last 15 years. The prevalence among adults has been persistently above 10%. And it's not for the lack of funding or programming. They're one of the most highly funded programs, or highly funded states by both the national program and by international donors in Nigeria. So they've had huge investments. They have more than 35, or at least they did at the time, more than 35,000 people on ARV. And he had noted, as the governor, that there had been no change in the HIV prevalence. And so he had come to our office in Winnipeg. He was on an official visit to Canada, and he came to seek knowledge about how to address the epidemic. And he had found his way to our center through Google. And so the question that occurred to me was, why would somebody who had all of these resources and all of these activities come to an academic research institution to seek answers and to try to learn about what to do about a pervasive HIV epidemic in a setting? And I think, so it stimulated me to ask this question of myself. So what can an academic institution contribute to HIV prevention programs? Well, academic institutions have skilled personnel from diverse disciplines, brings a culture of inquiry and innovation, fosters the dissemination of new knowledge and innovation, tends to have a commitment to train personnel as future leaders, and holds itself to high ethical standards. So these are all characteristics of academic institutions, which beg the question, why are we not more involved as scientists and as academicians in addressing the kinds of questions that the governor of Benue State provided? And I think it's because we're stuck in paradigms that we need to start shifting. So the challenge of HIV prevention, simplified immensely by this slide, is that we have been developing more and more efficacious interventions through discovery science and through efficacy science and clinical trials. But we're still challenged on reaching population impact and equity. And I would say that we're very strong on the discovery science and on the evaluation sciences, at least at the effectiveness and efficacy level, but we're very, very weak on the program science level. And I think it's the program science where we're going to have to focus some attention if we want to really start looking at how to achieve the kind of population impact and equity that leaders such as Governor Saswam was seeking. So we talk about interventions, and there are many interventions, an increasing number of effective interventions in HIV. But HIV prevention is not as simple as an intervention. It's many, many different interacting activities and interventions related to different populations. So if we look at, this is from an article several years ago by Shortlander and colleagues, which looked at the HIV investment framework. So this was trying to, in a simple diagram, explain what are the different ways that globally and in different countries we invest in HIV prevention. And you can see that you have a whole range of different kinds of components. You have critical enablers, you have basic program activities, you have different populations. So you have all of these different kind of components. And this really comprises the complexity of HIV prevention. It's not as simple as scaling up efficacious interventions. It's about fitting everything together in a way that you're having the kind of impact on the population prevalence and incidence, and also on equity. And so this is a very simplified version of how complex it is to achieve population impact. And I think there's plenty of evidence that we're not even getting some of the very basic things right. So this shows what the global fund financing for HIV prevention by different types of epidemics in 2010. So you have what are called low-level epidemics, generalized epidemics, and concentrated epidemics. And I'm focusing on the concentrated epidemics because these are epidemics where there's been evidence that if you have effective prevention programs for those who are most at risk of HIV, and you focus your resources on them, you should have a substantial impact, and in many cases could reverse the course of the epidemic. And you can see that in concentrated epidemics globally, only 16% of our investment from the Global Fund is going towards the programs for these key populations. So in this context, you can see that within that broader investment framework, we're still not even getting the basic investment decisions or funding decisions correct. Several years ago, with Sevgi Arel and other colleagues, we developed this concept of program science, which is not different from implementation science, but it's to try to take into account the broader set of decisions and complexity of piecing together a public health program. And I think it's important to distinguish between what is a program and what is an intervention. So a public health intervention is a specific technological or behavioral modality, generally. It usually has particular target groups, can be the whole population, but it specifies what the groups are. And as Nancy pointed out, the tendency in a public health intervention is to focus on effectiveness, fidelity to the intervention, and coverage, to scale it up, and to scale it up to have impact with the intervention. But a public health program is more complex. It has multiple components, meaning multiple interventions. There's a lot of decisions that need to be made in terms of resource allocation between components and how you can share things across components. So you can have multiple interventions, but you also have to think about how they work together. And the emphasis in a public health program isn't on scaling up and getting coverage of an effective intervention per se, but it's on optimizing the population level impact and the efficiency with which you can do that. And so in an HIV prevention program, you also have a very complex landscape of participants or actors. So you have policymakers and funders. They determine the size of the funding envelope, how much is required in order to achieve impact, how the resources be allocated and distributed, what should be the prevention priorities given the context in which they're making the decisions. What guidelines do they need for the programs and how these programs should be delivered? You have implementers and service providers who have to determine how they're going to use the resources they have and what resources they need, what sort of delivery models they're going to have for their different interventions. How can they achieve efficiencies and coordination, and what kinds of skills and capabilities do they need to implement these programs? And then you have communities or populations which have their own particular prevention needs or priorities. They have their own agency or capabilities in terms of their decision making, their own perspectives on programs, and then they face various different types of structural barriers and constraints. And so the funders or the policymakers and the implementers and the communities are all part of a set of complex relationships that are very interactive and dependent and interdependent. So the decisions that are being made at different levels and the resources all are dependent on each other. And so the landscape is much more complex than implementing an intervention. It's about all of these interacting features and factors. We have some problems with our current paradigms. And this is both on the program side as well as on the science side. On the program side, often we focus on scaling up a single intervention rather than on strategic funding. So when we have evidence that a new intervention works, we've got the gold standard or the platinum standard of an intervention evidence. Immediately what you'll see is a flight of resources into that intervention because now we have evidence that this is working. And so you have this sort of interesting dynamic where the evidence around an intervention sort of draws funding into it, regardless of what the context is quite often. Funding is usually in silos. So what you end up having is you have different funders who fund different types of programs. So this funder might focus on prevention of mother-to-child transmission. This one might focus on scaling up technical interventions. This one might focus on priority populations. But this creates all sorts of patchwork and silos of interventions. So you have structural interventions here, you'll have biomedical interventions there, you'll have preventive interventions there, but you have no real clarity about what gaps you have. You have very short funding timeframes, and these really focus on promoting short-term solutions. And the demand is for evidence about the effectiveness of the current programs rather than on the wider priorities. So quite often what programs demand is what you're doing effective, rather than asking, do we need to be looking at something different going forward? Science sort of mirrors some of the program issues. It tends to focus on studying the efficacy of individual interventions, often under ideal conditions. Funding really promotes investigator excellence and narrow topical focus. It's very difficult to build an academic career in this day and age when you have multiple different kinds of contexts. So it encourages investigators to focus. Again, short funding timeframes promote narrow research questions, and an increasing focus on impact metrics in terms of citation impacts, et cetera, promotes research for other researchers, not research for program planners or policymakers. This is a great article. I recommend it to everybody I speak with almost, by Parkhurst and colleagues, that really gets at this whole issue of how you change implementation paradigms and integrate science into the implementation of a program, especially a complex program. And what Parkhurst suggested is that we need to move away from what he called a GRIP model, getting research into practice, to a GROT model, which is to getting research out of practice. So getting research into practice talks about first developing clear, reliable evidence with a direct cause and effect relationship, and then trying to push that into policy formation, into implementation with fidelity, and then doing a program evaluation. Did it work? Whereas he's proposing that in the real world, we need to do more GROT, getting research out of practice, where we have evidence gaps, unclear causality, complex interventions, multiple interacting factors. We first have to develop hypotheses and research questions, hypotheses about what might work, design an intervention, and go to implementation. But through that whole process, continue to do operational research and process evaluation to see what's working, going back and reformulating our questions, formulating our hypotheses. So there's a lot more iterative process in terms of getting research out of an active program or intervention. And as you can imagine, this process requires a much longer sustained engagement between the researcher and the program or the policymaker. You can't do this with what we normally do in terms of our research models, which are really focused on the GRIP approach. So how would a program science approach differ from the current paradigms? First of all, I think it would expand our scientific research objectives to align with program objectives. So if the program objective is to improve the overall population impact and efficiency, that's the type of research research question we could ask. What would it take to do that? Or improving equity and outcomes. It would focus on those types of research. We've heard about embedded science. So I think it's important to embed science with programs and communities at all levels and link them together. So because you have the policymakers interacting with implementers and community organizations, the science needs to also be in that, it has to be embedded in all of those different levels. And then having an ability to sustain the engagement over prolonged periods of time, because we need to understand how the processes change and how they interact over time. I'll give a couple of very quick examples. And I want to start with the idea of what seems like a fairly narrow intervention, which is a program for female sex work. But if you look at it, a female sex work program has multiple components. You have community empowerment, you have addressing violence, you have community-led services, clinical and support services, condom and lubricant programming, program management, and organizational capacity. So this is all part of what's considered a comprehensive HIV program with sex workers. So you can see already you've got a complex array of different actors working together to provide a comprehensive program. And if you think about a program science framework in the context of sex work, you really have to consider this as a complex system. You've got the societal context with the sociocultural milieu, the demography, the economy, the geographic and political context, which creates structural barriers in programming. It also influences the differentiation of client characteristics or sex worker characteristics. The sex work organization is shaped in different ways in different places. So the way the program is organized has to take into account the sex work organization. And then you start getting down to the really proximate determinants, which are what are the aggregate properties within a sex work population, the client volume, or the condom use, or the duration in sex work. And then the wider structural components, like the partnering networks and the network structures, the cohort effects in sex work populations. And all of these end up driving the transmission dynamics and the HIV incidence within the population. So you can see that a sex work program itself has all of these different interacting components, but it also has these complex set of research questions that are integral to understanding how best to design the program. And so in taking the model of understanding things, what we've done is we've looked at embedding research within a program. This means embedding yourself with a state AIDS prevention society, with implementers and service providers and communities and populations, and a number of different questions will emerge depending on who you're dealing with. So if you're dealing with an AIDS prevention society, it's how important is sex work in this epidemic? What scale of program is needed? How should resources be distributed? What guidelines should we have for implementers? What enabling policies are required to support the research? Implementers need to know a number of other kinds of components. And within the community, it's important to understand the social organization and structures, the risks, the power imbalances, and changes in risk over time. So there's a number of different questions, and I'm just illustrating a number of papers that have emerged out of some of our work in sex work that show that the research that's emerged out of our program engagement addresses these issues, but the questions that emerged came from the program. These were not externally brought in by researchers, but these were questions that just emerged naturally out of the implementation of the program. There's a number of different initiatives. I could share them with you either publicly or privately afterwards. But we've been working in countries like Kenya, Nigeria, and India, where we've been able to embed the science within the context of a larger program. And what we found is that it's really enriched our ability to come up with the right questions. And it's not about finding ways of doing knowledge translation. The knowledge translation is part and parcel of what we do because we're embedded with the programs and the implementers and the community and the organizations. Does it have relevance for program science and HIV prevention in Canada? First of all, I think we need to think really deliberately about what kind of platforms we need for program science. This would mean sustained and broad-based partnerships between programs, research organizations, implementers, and communities. I'm not sure that we have them. I think we have them in patches, but I think we haven't really thought of a strategy for these kinds of platforms. I think we'll need to revise our funding models. They need to be more program-oriented, they need to be, rather than investigator-driven, and there need to be diverse funding sources from research funders, programs, and academic institutions. All need to start contributing their funding to this. And then I think we need to build capacity for this. We need policymakers and program leaders to be better able to incorporate research into their domains. Researchers need to learn how to do this better, and community members need to have their capacity built to participate in this. And I'm going to stop there with a, you can read this quote. It's a great article in Nature by Michael Givens that really talked about the importance of changing the social contract between research and society. So I'll stop there and thank you for your time.
Good afternoon, and thank you to our keynote speakers for their presentations. We're now moving into the discussion portion of this session and really looking forward to some dynamic dialogue. My name is Jessica Halverson. I'm here on behalf of the Public Health Agency of Canada. The agency has a keen interest in the ongoing discussions around program science, and so we're really pleased to be working with our partners, including the Ontario HIV Treatment Network and the Canadian Institutes of Health Research, to work on creating opportunities for dialogue, such as we have here tonight, to look at increasing understanding of program science and to build capacity to be able to implement this approach. I'm very pleased to introduce Dr. Peter Donnelly, who will be the chair for the discussion portion. Currently the President and Chief Executive Officer of the Public Health Ontario, Dr. Donnelly has extensive experience in government and public health program delivery, including having served as the Deputy Chief Medical Officer to the Scottish Government. Peter.
Jessica, thank you very much, and Sean, thank you very much for inviting me to be part of this. those were 3 great talks, but the remit I've been given is really to try and get you folks as a audience involved in this. So I'm going to very quickly come to you, and I'm looking to the back just for confirmation that I've got people with roving mics who are going to move around. I see 1 person, I see 2 people waving at me. Excellent. So the way we're going to do this, if you raise your hand in a minute, these people are going to get their daily exercise by running around the room and picking up your comments. The really challenging thing is we're going to have to do this in 20 minutes. So in order to facilitate that, I'm going to cede entirely my opportunity to make comment on those 3 interesting talks. And our 2 primary commentators who've joined me on the stage, David Ho and Aslam Anis, have very kindly agreed to keep their opening remarks brief so that we can bring you, the audience, in. But guys, let me turn to you first. Let me give you first stab at this while everybody in the audience is thinking of their questions.
I want to invoke a guy called Pierre Richard, who was a director of AIDS policy with the federal government when I worked there, and he moved on to be a senior director at the Canadian Institutes of Health Research, and following which he became one of the senior directors of the Canada Space Agency, which, as you know, is responsible for the Canadarm in the space shuttle. And this arm broke down one day, and it was one of the joints that broke. And so the Canada Space Agency repaired that joint and decided that the arm was ready for flight with the space shuttle. But what they discovered was, by repairing one of the joints, another of the joints reacted to that repair and was no longer able to function, and so the space shuttle program got stalled. And I think the lesson in that is that one of the beauties of program science is that we consider the relationships between the component parts. And one of the things that I think each one of the speakers has said that is so key is that we create tables and we create dialogue for the interrelationships between policies and practices. And one of the things that I'm really proud to say about the Ontario HIV Treatment Network is that we changed our policy 3 years ago to reflect exactly what Jamie said, which is that people that are impacted by the epidemic have got to be at the table, researchers have got to be in that conversation, and policymakers are at that same table. And that HIV research only gets funded if those 3 things are there, that the impact is the one that is decided by those people that are at that table, and that we need to learn to bring research to the systems that are operating between the 3. And so I think this is the beauty of program science, is that for the first time in the epidemic, we are now considering systems as well as all of the different components that we've been working with for so long.
David, thank you very much for being so concise and clear, making an important point. Aslam?
I'll be even more concise. As a health services researcher, program science makes a lot of sense to me. It's like finally there's a circling of the wagons coming together, trying to address the major concerns in our healthcare system. And so to hear things like efficacy to effectiveness is music to my ears, and then to recognize at the same time this complexity in the healthcare system, and it's not so easy to get to effectiveness. And taking the example of the 3 speakers, they all talked about PrEP. So PrEP is great, PrEP works, and it's been demonstrated in the Ipergay trial and the ROUD trial, and the recognition now that to make it work in the real world, it has to take not just a programmatic approach, but a program science approach. And I work in different areas, not just in HIV. And I was at another meeting with some colleagues who are very involved in the genomic revolution that's going on in medicine. And personal medicine is a big thing. And so colleagues there are talking about using the right treatment for the right person at the right time. And so all these things are coming together, but one thing we have to recognize that doing all these things are going to put pressures on the healthcare system cost. And sustainability of the system is something that we need to think about. It's not just sustainability of the healthcare system, because from a program science approach, you might want to reduce the budget for policing and incarcerating people and taking money from the welfare budget to put it into the healthcare system. So we have to start thinking about sustainability of the healthcare system with these great ideas. Thank you.
Okay, Aslam, thanks very much. Right, I'm going to turn to you now. I'm looking for questions. I may not do it 1 question, 1 answer. We may roll up 2 or 3 questions. So if I can see where my mics are again, I'm going to keep moving my mics around to where you are. So let's see some hands, folk, and as the hands go up, I'll just keep moving. The first one is across here, but can I keep having more hands, please? Okay, and then the second one is here. So if the first mic can go to this gentleman here, please. Okay, you got to run, guys, okay? You bring that one down here. Quick, quick, quick. I need some more hands up as well, guys, because we got to, okay. The next question is going to come from this chap down here. Okay, go.
Okay. I wanted to kind of unpack some of the tension
Bit closer, please. Hold the mic.
I wanted to unpack some of the tension that I noticed between program science and implementation science, as I understand it, and I'm relatively a newbie to those terms. So on the one hand, program science, you want to actually take a look at what's going on in that program and embed it within that program. For example, you talked about state, or maybe in our case, provincial or city aid service organization. On the other hand, we're being asked to, in the Implementation Science Initiative for CIHR, to examine the program in 4 different settings. So you're kind of, it's taking that specific thing and applying it in 4 different places, and you're supposed to be embedded in 4 different places. And I'm just wondering how that works, and how you could help us to resolve that tension.
Okay, hold that one in your thoughts, guys. Program science, implementation science, same thing, difference. Is there a conflict? Bring that mic down here. Yes, sir, go.
Mark Tyndall from the BC CDC, and I can kind of follow up on Trevor's point that one observation is we have Continuum CAHR to have 4 different tracks that don't talk to each other, so that's an obvious thing that we need to start thinking about, because what Jamie has really described is what I think is public health. Like, this is how we approach systems of how we make people healthier. And I have a great slide that I show that 3% of our budget goes to prevention and 97% of our health goes to disease treatment. And when the CHR presented their $1 billion for health research, I was noted that Gilead made $10 billion in 1 year for their hepatitis C treatment. So we're really got huge problems with the incentivization of our healthcare system that could make this happen. And so how we can really get that changed around, because what I see, if we're stuck trying to do this with 3% of our healthcare budget, then we can never do it. So we really need to re-incentivize our system, or maybe the question would be, how can we re-incentivize our system to get away from the treating disease?
Okay. Again, it's a comment rather than a question. I think the next person is here. Can you hand the mic to the lady behind, actually, because she was first. The lady behind. Thanks. Go.
Boy, I really feel this is like an efficient system
yeah,
here.
Yeah,
Boy,
yeah.
I've got to go fast. Okay. Well, let me put another idea on the table. How about life science? And the reason I say that is, people don't care about programs, actually. I mean, they don't care about diseases. They don't care about programs. Only people who think about programs are people like me when I was a public health doctor. People who think about research are researchers. The people who think about diseases are doctors. The people who want PrEP are people who want to have sex and not die from it. And ordinary people want to have jobs, and they want to have money, and they want to have love, and they want to have a safe environment. And if we're really going to take our lead from, person-centered or community-centered or population-centered research, we may need to even break out further from the limitations of how we think about the world in terms of programs, let alone interventions.
Okay, so we've got 3 things. I'm going to turn to my panel now in a minute. So we've got Program Against Implementation Science. We've got a call to rediscover public health, and we've got a call to remember people are at the center of this, and maybe they actually matter. Ladies and gentlemen, who would like any one of those? And then we're going to go to that lady there. Then I'm looking for other hands as well. So in fact, you're next, sir. So if the other mic can go to this, you're first, though, and then we'll come to that gentleman in front of you. But who would like to have a go at any one of those 3?
I'm happy to start.
Go for it.
Why don't I start with the first question? And I think there's sort of 2 elements to it. So I see a lot of complementarity and overlap, really, between program science and implementation science. And I think we shouldn't get bogged down in the language, right? It's trying to get the concepts right, and that's what we're all aiming to do. Actually, some of the approaches we're taking to the funding opportunities require that it is absolutely embedded within the program as opposed to the other way around, because we're not, for example, in Pathways, actually funding the intervention. So it has to be in a program in order for it to move ahead. And I just wanted to mention, you asked about, sort of the 4 jurisdictions or 4 contexts in your question. In the Pathways Initiative, we actually require 20 contextual settings. So what we're trying to do in writing that into a funding opportunity is to say, we're interested in contextual heterogeneity, and these are some parameters for that. You figure out what contextual heterogeneity is important, but it's an essential element of work in this field.
Okay. I think we're not going to fight about this then, okay? I think that's the message. I think Nancy's telling us that...
Unless Jamie wants to.
Do you want to chip in?
Oh no, I'm too jet lagged to be up for a fight.
Okay.
I think that it's a really important point, because it's hard to actually get a good program science initiative up and running and to get it embedded within the context and to do that well. To do it in 4 is that much more difficult. So my experience is that you do it, you start, and then you try to expand beyond that, and you try it in different contexts. But I really think the importance of heterogeneity and context is important, and it is an important part of program science. I think that's all I'll say at this point in time.
Just want to address the last question. There are 2 other concepts we haven't really talked much about today, but they're not in opposition to program or implementation science. So that's community-based participatory research. So I think that's really becoming more and more to the fore. So the it's surprising to me for the NIH for an adolescent trials network to say you also need to be doing CBPR, so you're actually dealing with proximate causes of problems. And then for a lot of the work that we do, community advisory boards are really important to keep us on track about what the people who are the end users of whatever we're going to develop really want.
Okay, I've just been whispering to a panel. It seems that everybody buys into the idea of rediscovering public health. Everybody buys into the idea of putting people at the center. You have a sale on both of those things. Aslam wants to make a comment, though.
I just wanted to comment or support Dr. Tyndall's approach. And I think what Mark was talking about is this re-incentivizing of the players in the system. And I would put it more starkly, and I'd say, is to stop thinking in silos. Because there are a lot of things that we can do if we want to make healthcare sustainable. It is already at the border, and we can't have no more money for new things. But we are doing a lot of things that work against each other. We have a lot of things that are going on that seem to not recognize that we can move money from different silos to make things better in the healthcare area.
Okay, and a comment to the right?
Yeah, I think one of the things that is lacking is the application of research to public policy. And that when the case I would like to see program science succeed at doing is creating the evidence that does in fact influence public policy. The cost of the epidemic is enormous. And I think I was sitting there a moment ago counting how much my health care has cost as a person living with HIV, and I think it's around $750,000. And I'm just one person. And I think the program science can make the case. And certainly nationally, apart from CIHR, which has made significant shifts in its new strategic plan to where the emphasis is going to go with their dollars, in terms of public policy for other aspects of the federal response to HIV, there's no application to priorities and no application to any program science implementation of what might be most effective, and I think that includes public health.
Great, thank you. We're doing really well. We're getting through a lot of stuff. So yourself, ma'am, and then in front, the gentleman in front, and we'll get response, and that might be us just about done in time. Yeah.
Just wanted to share with you that through the conduct of the Ipergay trial we did in Montreal, I felt we got a glimpse of that synergy between all these aspects of implementation science, because there had been a proof of concept that PrEP would work in certain settings. And what we were trying to do, and still are trying to do, is to adapt it and see in different population and in different individuals what would be the best tailored regimen. So in a sense, it was that in order to be able to be successful, we were a team, a fantastic team, people around me, of social scientists, of even virologists, clinicians, and bridging those 4 solitudes that we were talking about, but we did that inside the one, it was a clinical trial, but in a sense it was an implementation program of a successful intervention. So I just want to raise some optimism in terms of what we can achieve if we decide to make it a goal. And for me, I've been in an environment where people were opposing quite a bit public health to personalized medicine. And here we find a context where, you know, personalized medicine and individualized medicine can be a tool for public health, as in the case, for example, of Ipergay and this on-demand PrEP. So just my sharing of my experience.
Thank you. An important point. Yes, sir, you're next.
I want to thank the presenters for providing, at least for me, a framework for actually thinking about large problems and big problems. I've gone from being a clinician to trying to think about public health issues to basically turning into a researcher. And in our province of Saskatchewan, which has the worst HIV epidemic probably in the developed world to a large degree, I guess the tension that I have is how should programs be funded and who should fund them? I don't see that it is CIHR's responsibility to fund programs that are then subsequently evaluated. I see that it is the responsibility of our government to provide that funding and support for programming to occur, and then for researchers and research funding to allow for evaluation and for, you know, plans around scale up and so on and so forth.
Okay, thank you. A genuine question I'm going to leave for the panel to think about a minute, which is who should fund. I'm going to take one last comment from this gentleman over here and then let the panel respond, and then we're done in terms of time. Yes, sir. Can one of our runners get the other mic across there? That one seems to have died.
I think it's on now. Thanks for very interesting presentations. And part of the message I was hearing is that in traditional model of research, the research kind of leads and then the program follows, in the sense that there's a proof of concept and then an adaptation and take-up. But in the program science model, you're talking about the programs leading and research following. And it seems to me that that raises some fairly significant structural issues around research itself and how the research machine actually works. So my question is, to what extent are these structural issues being looked at within the research world and within CIHR and other research institutions?
Okay, so we're really short of time. So here's what I'm going to do with the panel. Folks, you have two questions. One is who should pay, and the second one is this a problem that we have program lead and research follow, yes or no? You can also choose to answer neither question and just make a closing statement, but either way, you've got to be really brief. You've got a maximum of 1 minute each. I'm going to go left to right.
Okay, so I once stepped into the office of the director of a national AIDS program. And he politely looked at my card and saw that I was from a university. And he said, could you please just leave your research paper here? I've had 6 other professors in here showing me the research about what works. And so that's very nice, but I actually have different questions. And so I think that this is the exact problem that we have when we want to influence policymakers. We need to understand what their questions are. And their questions are not the same today as they will be next year. And if we're not embedded and let the program lead, then we will always be out of tune, and we won't have a receptive audience for the questions we have. We can involve all of the different scientific groups in the research, but unless we're following the program, program managers are going to turn a deaf ear to research for the most part.
As a visitor here, I wouldn't presume to talk about what the mix of funding should be for various quarters. But I think PrEP offers a very interesting opportunity and perhaps a paradigm. In the US, we don't have one healthcare system. We have multiple healthcare systems by the state, and they're really quite chaotic. So I live in a very progressive state, Massachusetts. This is highly available, and a lot of programs are already adopted it. Other places, it's going to be a big, big fight. Here in Canada, you have much more of a national system, and I think many people around the world in industrialized democracies can learn about what you're going to do in terms of translating the data that's just come out from the trials into program and implementation.
Nancy?
Yes, I think we've been missing the boat on a number of the kinds of questions that our policymakers have. We're not even sometimes providing basic cost information. You can't even set up a budget without costing of a program. So we've just got to be more in tune with what those issues are. We have a lot of boutique programs out there which are non-scalable right from the get-go. We try to sell them to the policymakers, but they're not scalable in terms of financial considerations. So I think there's a dialogue that we need to be engaged in to understand how to go forward. How do we get out of this approach we're in, where we have often been called a land of pilot studies and pilot projects? That's both the program side and the research side. And I think your point is very well taken, the last speaker, around the structural issues. That relates to incentives in university, the publications count, other things don't, ethics approval. There's a whole litany of them that we're really going to have to look seriously at to move the science in the direction that we're talking about. So thanks for that.
Nancy, thank you. Aslam, and then David will have the last word.
I'll just try to close by trying to maybe answer a question at the same time as trying to say my last remarks. And it refers to the question by Alex Wong, who said that who should be paying for the programs? CAHR is trying to roll out a new initiative, and I had this hallway conversation with Jennifer here, who kept saying, what should be an eligible expense? Well, if you want to have a good program science model, and yet the programs are not funded by the regions or by the health system, then you can't evaluate them. But CAHR can be funding them. So it's a difficult question and a difficult problem, and I'll go back to my initial comments where we start breaking down silos between program delivery and evaluation.
Okay, thank you. David?
If it's true that research has been leading programs, I should say it stops. And if programs assume that they can lead research, I would say don't. But I would say talk to each other and we might get somewhere.
Okay. Ladies and gentlemen, apologies for being a bit of a bully to make you all get your questions in, but I thought you did a great job. We covered an amazing amount of things in 20 minutes. So thank you to you. But please join me in thanking what was a fabulous panel.